Person supervisor, all docs is all docs. Yeah, because if I were in here, I would read you and I would be very therapy specific on what I'm giving you. Yeah, all docs is all docs. Right, Harry? Yeah, so if you're working the weekend and you need that information and you can't access all docs, go ahead and call the manager that's on call for the weekend.
Question?
I'll tell them.
Do we put our PT diagnosis in the diagnosis too? Or do we just use from the H&P diagnosis, and then in our body of our summary we put our PT diagnosis in the reason we're seeing the patient?
That is right here. That's this.
Okay.
That's where you'll put it.
Okay.
So don't restate it.
Don't restate
No,
it.
don't restate
I don't
it.
want you restating
Okay.
it. Yeah, that's where that's going to go.
Okay, thanks.
Can you guys scroll it back to the top? Like
Which
to
is
the top.
this, these four.
No, but when you chose at the top, it would help her because she was by her. But you guys sent us this in the emails.
Yes, it was sent to me.
I'll just search my email and find it.
That's Harry's fault.
So can you get us? There it is.
Yeah.
Make sure you can access work email from your computer. And if you can't, one of the IT guys will assist you.
Yeah.
And we want to do this starting today.
Starting yesterday.
Yeah, only because we know we're going to have that.
So I know I'm still learning computer. I'm not that well versed on computer, and I'm guessing there's some people that are going to ask him a question about how to download onto the file or save to the desktop to copy and paste. If there's anybody that doesn't know that, who do they go for assistance?
I would say Stephen, when he's here, would be the most appropriate, and Harry second. And if they're not available, I'm sorry. You know, Stephen is really
Computer savvy.
very computer savvy.
Better at the computer than I.
Yeah. So when you do a save, it'll ask you, will always ask you where you want to save
Come
it.
see me. Come over to my desk.
Yeah.
We'll do.
IT.
But you can go see Lonnie. If you're here, you can ask
Just come over.
Lonnie, Ben, Mark.
Save it.
You need a ticket for that, right?
Yep.
You don't.
I would.
You would?
Yep.
Yeah.
And Mark is good getting up the email. He's a good choice for if you're having trouble with your email.
Definitely, he definitely knows it.
No. Another question. Deidre, sometimes I think there may not be any documentation in all docs to support something that we know the patient says they have, and we need to treat them for that. And haven't you sometimes called the doctor and got confirmation on a diagnosis?
Yeah, but we've always had to have it in writing,
You have to have that in
So
writing.
then
so it has to come in writing.
So they'd have to have it faxed to the office.
Yeah, there has
What
to
is
be
the
that.
fax number that, then in that case, that we would give them?
Harry?
What I recommend is that you let us know that the diagnosis is not in the clinical record, and then myself or Stephen will assist in getting that information. I've done this on a number of occasions where I'll actually call the hospital, call medical records, and get them the fax MRI results or the neurology report that didn't happen to come over with the initial referral. So we are interested in getting the right diagnosis, accurate diagnosis that supports the plan of care. Right, 714-712-7254 is the rehab fax number.
Say it again, Harry.
Last four digits are 7254.
But essentially, you can do that for us, is what you said.
We will help. We will help. You gotta give us some idea what you're digging for.
Right.
And I know
One recommendation I would make, if you do see a discharge summary in written form in a patient's home, and you don't see it in all docs, I would ask the families and the patients, because a lot of people do have fax machines or scanners in their house, and I would get a copy and then just turn it in with the consent form, and then that will get scanned into all docs. It'll
Yes,
get
it
turned
will.
into medical records. So sometimes those are really current and pertinent information. So, you know, keep your eyes open, because sometimes they don't send it to us.
Sometimes I've called the home health liaison nurse too. If there's something that we're looking for, documents for rehab or even tests, they can put those in too, because they don't always have them all Xeroxed all the time or scanned.
Correct.
They don't.
Okay. Anything else, Ken?
For me,
More questions?
Okay, thank you.
Do we know any more as far as the process of data coming back from select data and what's gonna happen with that and how it impacts them?
Actually, initially, there's gonna be no change as to what's going on now, how it's gonna impact you. It's,
So we're still gonna get a task from the UR
correct.
if there's any changes in.
It's gonna be from the, yes. At this point, there's not gonna be any change.
So the goal of having the outsourced company is to help give us more recommendations as how to perform our OASIS.
The recommendations that are gonna come down are gonna be for not only the diagnosing, but also OASIS questions and things for the 45. Not unlike what you're getting now from your UR representatives, which, you know, for your UR staff, which is Deidre and so on,
Okay.
In all the nursing homes.
and all the nursing homes. It's gonna be pretty much similar. They have a PDF form, but you're not gonna worry about that. We're gonna deal with that internal process. You will still get the task and, you know, check your clinical note, and it's gonna be the same. Okay?
For like a hip replacement or knee replacement, for primary diagnosis, are we writing like total knee replacement, or we have to write the aftercare total knee replacement? That kind of stuff?
I would write aftercare for a total knee replacement. Just-
And like some other like main diagnoses that they code are like other physical.
That's the
nerve.
1022, that's the other diagnosis.
So we write that in, or will we write lower extremity weakness?
You could do that, whatever, well, it has to be corroborated. It has to be corroborated by the physician in the documents that we have. And if it's not documented by the corroborated by the physician in the documents that we have, then you'll need to call the physician and ask them to send it over with their signature to the fax number that was given.
For rehab diagnosis, they don't put it in usually in the physician's notes. For rehab, they're a bit difficult to put that in. So what do we do with that? We
Yeah,
can
they
find
have
it
to
there.
abnormality of gait.
Yeah. So,
Don't put it in.
Well, but that's,
That's what
that's
I
your
mean.
classic. For knees and hips, that's your classic.
But what they're pointing out is
Difficulty
valid.
walking is
We
one
don't
too.
even Mel, the coder doesn't always put those in, and then as us
And that's
reviewers.
because there's no documentation. And if
Well,
there's
but
no
if-
documentation, we can't get it. And if we want to use it, we are going to probably have to initiate the physicians.
Well, it's sort of, I'm just saying, there was one specific case where we did not have a dysphagia in there, and so I went to Vicky, and the doctor is relying on that speech therapist to make that actual diagnosis, because that's the person that knows whether they have the dysphagia.
Mhm.
So, these are the ones that know that there is a gait abnormality or the muscle weakness.
Unfortunately, because of the rules are, and trust me, I know that. I know that you guys are extremely capable in identifying what the issues are with these patients, and probably even from a diagnostic standpoint. However, the rules are the rules. And we have to comply with the rules.
So when we call to update the doctor, can we just say, do you agree with abnormality of gait and weakness as a diagnosis? And just include that in our phone call and say that we verbally
You can say that,
Okay.
and you have to say who you talk to at the doctor's office in order to get that corroboration. If you do that, you have to state who you talk to at the doctor's office to get that corroboration.
So in that case, you don't have to get the facts?
Well, it's,
Because it's verbal.
no, if you get the verbal and then they sign the plan of care,
That's good enough then.
that should be, okay, what Select Data will do, and initially they said, we want documentation that the clinicians called the physician for all the diagnoses, and I said, no. I said that most, most of them are in, so they should be in there, but when you come to these outliers, and what they said is they said, physician was contacted and corroborated these diagnoses. So, yeah, if you do that, I'm fine with that. And as long as the physician signs the 45, we're good. But you have to say, say you call the doctor's office and they put you through to the PA, and the PA's name is Joseph. Spoke with Joseph Smith at Dr. So-and-so's office.
We need
First
first
and
and
last
last
names?
Yeah, there has to be the first and last name.
Yes.
Because I've been seeing some just put PA or MA.
No, that's not good
You
enough.
have to have
First and last
that.
name of every person we talk to now?
No,
I was just-
no, when you're getting pertinent information.
Yeah.
When getting pertinent information, yes.
That's when you get to make it up. No, I'm just kidding.
So if you get right,
Usually when it's all fixed
if the diagnosis you know that this diagnosis applies to this patient, but you can't find it anywhere, but you know it applies in this situation. You call the doctor's office and you talk to, you get the PA's answering service, you know that, you get the voicemail. But they tell you which PA they're sending you to. You need to write.
No, sometimes no.
Then you need to ask before they send you, say, who am I sending, who are you sending me to?
Sometimes it'll go on days.
Well, then that's
When you call them, you know, you open up the whole thing or something, they never look at the welcome or any of that stuff. What are we gonna do at that point? We're not gonna get a hold of anyone that's gonna give us that
you can, and that's okay, because you can put another note. And I know it's another note, but you can go into healthcare and put another clinical note and say corroborated with at that point.
But we won't be able to finish our clinical notes right to that assessment.
You can finish that clinical note and add an addendum to that clinical note. You can add another clinical note the following day, saying, addendum to, you can do that.
Two questions. Are we putting anything on the PT evals at all in terms of the code? Like if we come out later, or just nothing? It just depends.
Well, you have to put something in there that won't let you save to 100%.
No, I'm saying
like,
relating to the coding.
clinical note.
Because you know how like the nurse is going to come out, they're going to do the start of care, they're going to answer all these questions. Now we come out, we're going to have our own separate diagnosis for why we're saying that. Do you want us to put that
Yes.
somewhere?
Yes. We didn't come up with a clinical note to do that, but I think it's gonna be extremely important. Just as well if you
Because
happen to.
every discipline, OT, PT, speech, is going to have their own reason for
Right,
seeing the patient.
It's a good question, and I think the answer would be yes, because if you get your information in within the 5 days, they're going to roll that into.
The only way they will roll it in is if you state that you gave that information to the admitting clinician. And the admitting clinician has to say, I approve of it.
What information is this?
Your diagnosis.
The
Remember, it's the one clinician.
The same thing.
Pass the nurse.
Same thing that health.
Well, it's not
The patient has gait abnormality, and they listed gait abnormality, but they didn't, and so they just had a total hip replacement, and muscle weakness isn't in there, and we're doing exercises with the patient. Are we treating something that we shouldn't be treating then? Because
Yeah,
muscle
that's where
weakness
the
is
problem
never
is.
in there.
That's because nobody ever writes it, no physician ever writes it. That's
Exactly,
probably
it's
why.
never in there.
Or
Or we get UTI. We don't get weakness.
However, you know, I'll just go back to the question we answered before. If you really think that muscle weakness is a really important diagnosis, you call and you let them know that, but you need to get the first and last name of the person, and you have to write who told you. You know, who you spoke with in the physician's office.
Because like with the CVA, for instance, muscle weakness is included in that diagnosis, and
Correct.
so is gait abnormality. So when the
Correct.
coders code CVA, even late effects
Late
CVA,
effects. And they, but when they code the late effects CVA, it's specific to what late effect it is. And that's why it's inclusive in the code.
yeah, because I've asked them to add muscle weakness and gait, or is that included, and they said that's included, so.
Right, because there's a specific code for late effects CVA, you know, hemiplegia of dominant side versus hemiplegia of non-dominant side. And that's why it's included in the code.
So
You
do
don't
we
need
need
to put
to
that.
include dominant and non-dominant
I
CVA
thought I missed one.
in the note?
Well, what the,
Yes, you need to.
it would be nice.
Much detail, especially when you
It
go
would
to
be nice.
ICD-10. And ICD-10 is going to have 70,000 codes, 40,000 codes or something. So if you don't have the specifics, they will have to call you back and say,
Yeah.
which leg, which.
Unspecified.
Should we train the doctor to put the
Yes.
But it sounds like it's something that has he's gonna do it.
That's why you guys are adding your, we've been asking you to put an O by your clinical note, because then your note is going on the 45, and so that helps solve the problem that the doctor doesn't write a complete face-to-face, but your documentation supports the reason why that person needs your care. So that's why that habit was changed, to put the O by your clinical note, then it goes on the 45.
But if we're doing eyes for starting
The eyes,
first,
I
then
don't-
that's automatic.
I would say
That's
ignore
only-
the eyes, Deidre can decide if you, the problem with the eyes, it only works if you document that day and put that eye in that day. Otherwise, it does nothing.
So we want O's now? O, C, P, and N's on starter cares, clinical notes,
Yes,
and not I's?
yes.
So, I didn't evaluate today. My patient doesn't have lymphedema in their long list of diagnoses. I need to call the doctor and say, can I please add lymphedema to find the ICD-9 code that you sent to me?
You don't need the
No,
code.
you don't need
I don't need the code.
You don't need the code.
The words.
You need the words.
The coder at the agency will do it.
Where do I put in the list of diagnoses here?
No, you just put it in your clinical note.
Oh, I did put it in my clinical note.
That's all you need. But you need to say, spoke with, you know,
Well, I did want to take Dr. Jessica.
Jessica who? Jessica Rabbit.
I already found out.
Get together. Somebody doesn't
Are we supposed to have the diagnosis tab, right?
The diagnosis tab is still gonna be there, and at this point, my understanding is that Select Data will put the diagnoses in.
So when we, sometimes we'll use like a starting care, there'll already be like a list of some.
Well, sometimes because we have repeats, and sometimes they're in there from that. But what will happen is that Select Data will put the appropriate codes in.
Okay, so can we look into, do that as part of our?
No, so let's say it's after you guys.
Yeah, it's after us, so it won't be there.
You're giving them the information so they can put that code in there.
Some of those codes were flew over from another episode or something. Yes, Tina.
So on all those other diagnosis codes, like, not codes, but coding, like depression, AFib, all the stuff that we're not really necessarily, COPD, CHF, chronic edema, all of that stuff, is that supposed to be all typed out too under other diagnoses? Like if they have a medication for
And really, it's what's appropriate.
CAD or
It's really specifically to what's appropriate to the patient at this point in time. If they had, give me a second.
Hyperlipidemia, high cholesterol.
Right, hyperlipidemia and high cholesterol, and they've had it controlled for 20 years,